You're listening to the JA Talks podcast, created by JA patients for JA patients and the people who love them. Here, learn what it's like to be diagnosed with juvenile arthritis at a young age and tips and ideas from our hosts and guest experts.
Welcome back to another episode of the JA Talks podcast. I'm Bailey Bowman.
And I'm Kate Wingate.
And we are so excited that you've joined us today. We also have another amazing JA patient and Arthritis Foundation staff person, Claire Eby. Claire, do you want to tell us a little bit about yourself?
Yeah, hi, I'm Claire Eby. I was diagnosed with juvenile arthritis around age 3, and that kind of turned more into uveitis as I got older, like within the next 1 to 2 years. And so I've been dealing mostly with the uveitis part of arthritis. But yeah, I'm really excited to be here, and I'm excited to talk a little bit about JA.
And we're so excited to have you, Claire. Also joining us today is our guest expert, Dr. Heather Von Motter. She's actually my pediatric rheumatologist at Duke Children's Hospital, and I am so thrilled to have you joining us today. Dr. Von Motter, hi.
Hello. Thank you guys for having me. I'm excited to be here.
And with that, I am just going to jump straight into some questions, if you don't mind. Just to start off really broad, how long have you been a pediatric rheumatologist, and why did you decide to become one?
Oh, such a fun question. So officially a pediatric rheumatologist since 2009 when I graduated my fellowship, but there's 3 years of training that you do in pediatric rheumatology after you do your general pediatrics training. So I like to say I've really been practicing pediatric rheumatology since 2006 or so. And I kind of fell into pediatric rheumatology, to be honest with you. In medical school, I didn't really have rheumatology on my radar at all. I saw a few patients in the hospital, but as you guys know, with juvenile arthritis, most patients with rheumatic diseases are not actually hospitalized. So I did an elective in my last year of pediatric training, January, my last year of pediatric training, and was kind of like, well, this is an interesting group of patients. It's really like a fun group across the age spectrum. We had really new treatments that were coming out in that kind of time period around 2010. It got really exciting about the treatments and how much better we could make people feel. And so I decided to become a pediatric rheumatologist, and super excited. Some of my colleagues, my first year as a pediatric rheumatologist, are like, Heather, you're always smiling. And I'm like, I know, I just love it. Just such fun patients to work with. And it's really fun to be a part of watching you grow up. And as you know, Kate, we've known each other a long time, and it's such a privilege to be able to be a doctor and follow kids into young adulthood and on. So
that's so exciting to hear. And I'm so glad that you still seem to enjoy it as much as you did in medical school. That being said, our title actually for this episode is Diagnosis Difficulties. So I did kind of want to ask, I know you've known me and my story forever, but in my experience, there's no set test for JA. How do you as a doctor determine that diagnosis, and how long does that usually take?
Yeah, so it's one of the things that makes rheumatology a little more challenging is that there are very few conditions in rheumatology. There is a test that tells us this is definitely what the condition is. So it's a lot of findings on the exam. So the exam is a really important part of diagnosing rheumatic diseases. And then the history, which is why any of you who come for a new visit, you'll be like, why are they asking me so many questions and very specific questions about this timing and this duration and things? Because there are certain patterns that fit with when you have joint pain from arthritis versus when you have joint pain from a chronic arthritis or even an infectious arthritis. I think that's one of the things that gets complicated sometimes is we use the term arthritis, but it doesn't just mean chronic arthritis like JIA or rheumatoid arthritis. It can be osteoarthritis, the kind of wear and tear arthritis that can happen after an injury, even in kids. It can be an infected arthritis or inflammation of the joint. So part of what we're trying to figure out in that beginning part, is this infection related? Is this more chronic? Is this part of another condition that can give you arthritis too, like lupus? Or there's lots of reasons to have joint pain without actually inflammation in the joints. And so that's part of what we spend a lot of time on, the history. And then the physical exam is really important. To have a diagnosis of arthritis, we have to see signs of swelling in the joint, warmth, pain on range of motion, loss of range of motion. You actually need a combination of those things. Some joints are a lot easier to check for. We can, often tell knee arthritis really easy, but sometimes the ankles can be a little tricky, or the wrists can be a little tricky, or what about the small fingers in a 2-year-old, right? Little pudgy little joints. So sometimes we have to use other tests to help us, x-rays or ultrasound, or sometimes even an MRI, to really get a full sense if there's inflammation in the joint. So sometimes that diagnosis can take a longer time depending on how you present. So if you present with a classic history of juvenile arthritis, which is kind of a smoldery, kind of subtle onset over time, a little limping, a lot of morning pain and stiffness, all of you with arthritis know these things, right? You can follow come in the room and we'll be like, we know what this is. We see you have classic swelling. You've had it going on for a while. We've got some basic labs that support it. We can make a diagnosis pretty easily and pretty quickly. I say that as a pediatric rheumatologist. If you're a general pediatrician or a family doc who hasn't seen a lot of arthritis, it can be a little trickier. That's like trying to get that referral sometimes can be really helpful. But some kids, even for a rheumatologist, are hard to diagnose, right? They can be subtle findings, a lot more pain than we can see inflammation. And so we're really trying to figure out, do you have arthritis or is there something else going on? And those can take longer. We are fortunate nowadays to have better imaging testing. So MRIs are really pretty good. It's hard to hide arthritis on an MRI. You could argue it's not perfect because I say nothing in medicine is perfect, but it's probably about as close as we can get to perfect for arthritis. Most kids, though, don't need an MRI to diagnose juvenile arthritis. We can do it by exam or an ultrasound or an x-ray. But just depending on how you present, how old you are when you present, things like that, it can take a little bit longer.
That was so insightful because obviously I don't remember my diagnosis journey because I was 15 to 18 months old. But the story told time and time again is Dr. Rabinovich walking in and saying, we know what this is and we know how to fix it. And for my parents who had been turned away and it took a lot of time to get a referral and stuff like that, it was like the heavens came down. It was such a blessing.
Yeah, because it can be really tricky in toddlers because a lot of times they won't want to walk or they kind of don't meet some of those developmental goals that we look for, like walking by this age, running by this age. And there's a lot of things to think about that can cause that. And sometimes if you have both sides affected equally, it can be harder for people who don't see a lot of arthritis to tell, as opposed to if you have one side more than another, sometimes it can make it easier. So, but yeah, young kids can be really tricky to tell because they can't complain a lot. They often don't complain a lot because it's all they've ever known, right? And so they just kind of are doing their thing. I think one of the other tricky things with arthritis, as you guys know, is you have a lot of morning pain and stiffness, but as you get going, you feel better and you move around better, right? So even for parents, sometimes they're like, well, they were kind of not doing great this morning, but then they were fine the rest of the day. Sometimes it's hard to kind of pick up on the fact that there's really something chronic going on. So,
Claire, I don't know about you, but I was one of those that it was like, this is for sure what you have, because I walked in and my knees were probably the size of softballs.
Oh gosh. I was one of those kids that was a little bit harder to diagnose. And I live in a really small town, kind of in the middle of nowhere. We're pretty far away from any major cities. And so when I was diagnosed, they just put a cast on me, which is not what you want to do when you have arthritis. So I had that cast on for a little while until I was able to drive the 2 hours with my parents to a pediatric rheumatologist in Dallas, Texas. I personally always had to travel that 2 hours to see my pediatric room for all my appointments because that was the closest that we could get. So that kind of leads me into my next question, which for you, Dr. Van Mater, can you kind of speak to the lack of pediatric rheumatologists in the country and how does that affect your day-to-day schedule, you think?
There's pros and cons. We have a really tight-knit community of pediatric rheumatologists, which is really fun because we can call each other up. We know who are experts in different areas and we see each other at similar meetings. And so you develop these nice relationships. So that part of the day-to-day, I think, is an advantage, but it's really hard when we have patients that are traveling really far, as you mentioned, because sometimes we really need a physical exam to know what's going on, right? But what we're learning, and honestly, what COVID kind of helped us learn with video visits is how much we can do with video visits or online kind of things, which has been really helpful. Because it's already hard to have a chronic illness, right? You're already missing school for appointments and if you have to go to physical therapy or any of those other kind of things too. So we don't want to have unnecessary extra visits, especially when you have to travel 2 hours each direction. So that does make it a little bit more challenging, I think, for us. We want to be really thoughtful, like, do I really need you to come back? How much can I get away with doing locally? How much can I partner with your pediatrician? Because sometimes you go to your pediatrician and be like, whoa, I don't know, I don't do arthritis, and you're on these medications. I don't do methotrexate, right? And so how we can kind of partner with them to kind of make them more comfortable sometimes is both challenging, but also rewarding. Getting local labs, which is great, but then at the same time, sometimes we're trying to run those back down. So that can sometimes take some extra time when the lab forgets to fax us the results. And you're like, no, I got my blood work. And we're like, we don't have it. So I think those are some of the challenges of it in the day-to-day work. I think more the pediatric rheumatologists recognize that it really limits access for rare conditions when your local providers aren't as comfortable, they don't see it as much, to really make those diagnoses early. And so there's a lot of work amongst the Arthritis Foundation and the American College of Rheumatology to really try to partner with primary care providers to make them more aware, to teach them the basic exam, to do what they're kind of looking for, and then making sure we have easy access. So we get a lot of calls and electronic referrals, or even just questions like, I have this kid. One thing that we didn't talk about yet is labs. So a lot of times pediatricians or family docs think that you're going to have positive labs if you have arthritis or juvenile arthritis. And most kids with juvenile arthritis, as you guys probably know, have pretty normal labs. So you can have some people who have very high inflammatory markers or very high positive ANA or rheumatoid factor. But a lot of kids, even with really a lot of arthritis, can have completely normal labs. And so that's one of the things we have to always be working to educate local providers on, because we don't want to not have them refer those patients when they get the labs back and like, oh, the labs were normal, so you probably don't have juvenile arthritis or rheumatic disease. And we're like, whoa, wait, we probably still need to see them. So trying to educate people on that. So I think that's one of the challenges with so few pediatric rheumatologists, is really trying to fill in those gaps, because we also don't want people to drive 4 hours for no reason, right? So if we can get that care and rule out juvenile arthritis where you're at, then that's great too.
And with that, what should kids and families do if they don't have a local pediatric rheumatologist? If they are in one of these rural areas and they think that they might need to be seen, what's kind of the best steps for them to get in to see one, or to know that they even need one?
Yeah, so I think a lot of times adult rheumatologists fill this role. It's actually something I looked into during my training. It's this partnership between pediatric and adult rheumatologists. That definitely is easier if you're a teenager, because that kind of, once you become a teenager, your kind of exam overlaps quite a bit with adult providers. It's a little harder for an adult provider to examine a 3-year-old, just because the joints are quite different in a 40, 50-year-old person versus a 2 or 3-year-old person. But that's often a place where people will start. And then some pediatricians in different areas or orthopedic doctors can be more experienced in those kinds of things. And that sometimes is a situation where it's not the wrong thing to get an ultrasound or an MRI earlier to help make that, to determine if there's really inflammation in a joint that seems to be bothering kids. For those local docs to call, we get a lot of calls from people even across the state lines, of providers who are like, I'm really kind of worried about this. We live far away. I'm not sure I really want to send them there. What kind of basic stuff can I do first? And I think almost all pediatric rheumatologists are really willing to help guide local providers to help with some of that basic workup, so that we can make sure that you're getting the care in a timely fashion. And if we make a diagnosis of arthritis, or they make a diagnosis locally, then trying to figure out, could you see an adult provider? Some family practice doctors are more comfortable with some of these medications because they use them in their adult patients. So kind of who's going to be your care team? And we do a lot where sometimes we see patients once or twice a year, and then they follow with a local adult rheumatologist closer to home. So we have this kind of partnership where we can kind of weigh in if there's a question about how growth and development may be affected, or some of the school issues, medication choices, but otherwise you follow with somebody close to home.
What would you say is like a piece of advice that you would give to the kids in specific that are just starting out with a pediatric rheumatologist? It's their first appointment. What would you say to them?
Pediatric rheumatologists are fun. We're a fun group of people, so don't be too worried. It's going to be fun. I think one is just to be honest, describe your symptoms. Don't feel like you have to know the terminology. I think sometimes people have read things and they're trying to use the right words. Just tell us how you feel. That's the most helpful for us in terms of how you would describe the pain or the stiffness or the sensation and what your limitations are. We're going to ask you a lot of questions. Just be ready for it. As Kate's heard me say many times, I'll be like, here's the 50 question portion of your visit, right? We're going to run through a lot of specifics. So just kind of be prepared for that. It's never comfortable when people are asking a lot of personal questions. I'm a doctor and I don't like going to the doctor, right? It's like never really fun, but it's just really important. So we may ask you weird questions or uncomfortable questions, and all of those things are really important for us to be able to make decisions about what's going on and what might be the optimal treatment for you. There is often blood work required. that is usually the thing that freaks people out the most, is the getting a blood draw. And I wish we could not have to get blood draws in all situations. And we try not to if we don't need to. But in order to make a good diagnosis and really figure out what type of arthritis you have, as most of you know, we do need some basic blood work to make that assessment. And so Kate may remember this, but I always say, give the tip, like just try it. If you don't want to look, don't look. If you want to look, look. But whatever you do, keep that arm relaxed, because if you tighten it up, it's going to hurt a lot more with that blood draw. And there's a lot of things that you will learn to overcome when you have arthritis. And this is one of the first things that you will probably have to learn to overcome is getting the blood drawn. And the more you can take some deep breaths and not let it control the visit. Some kids get so anxious about it. It's like they don't even want to talk. They don't want to tell us the story. I often will say, Kate knows this too, like, your body's going to tell me. So you can say, no, I don't have any joint pain. I'm fine. But I'm going to examine you. And if you got arthritis, you got arthritis, right? If we're going to need labs, we're going to need labs. So you might as well just be honest, because it's unlikely that not telling us the truth is going to sway us in the end from if we need to get blood work or not. And there are different strategies. There's different numbing creams or cold sprays and things that can help a little bit too. So make sure you ask your providers for that if blood draws is something that really stresses you out. A lot of places will have Child Life. So we have really fantastic Child Life that have gotten much more involved in the last couple of years at our institution for doing the regular blood draws, as well as IV placements and things, to really kind of help kids learn some strategies to handle that stress and that, immediate pain of getting those procedures done. So if you're in an academic center, especially, that's usually where you're going to see more Child Life specialists. Ask for that if that's a resource. Even if you've been a patient for a while and you didn't know that was an option, ask if they have that available.
I was a numbing cream kid forever. I mean, forever, because we would do methotrexate at home, and obviously that would come with side effects. Mm-hmm. So whenever my body needed me to get something out of my system, say I was sick, for years, and still now, I would phantom smell that numbing cream because it was associated with methotrexate and those side effects. But that being said, I was a numbing cream kid for years. I go into my sticks and I'm a pro. Going along with that, actually, and how kind of I've had to learn with my experience, Dr. Von Mutter, do you often run into parents speaking for their kids in times like these? And if so, how, what's a piece of advice you can give? How can kids further self-advocate and kind of learn that skill? Because obviously everyone's different. In terms of, introvert versus extrovert. But I feel like there definitely needs to be more self-advocacy.
And I think it varies kid to kid and parent to parent. So I'm a parent. And so, it's very hard as a parent when your kid has a condition, you have a lot of questions yourself, right? And sometimes because you've been taking care of them, you kind of interject your thoughts and feelings, especially if you're young, like the kids younger when they're diagnosed, kind of helping kids learn that autonomy as they go along. So I think part of it's on the provider to kind of make sure we're asking you questions and to make sure that we're making eye contact with you as the patient. Sometimes parents need a reminder, like, oh my gosh, I'm so excited to hear what you have to say too. But right now we're going to hear what Kate has to say and kind of get her perspective. And then I'll come to you and see what you agree with and what you've seen differently and things. And then I think sometimes you can have that I don't want to say sense of humor, but it can be aggravating, I think, for teenagers, especially as you're trying to kind of figure out your own way of doing things and trying to speak for yourself, not even just at the doctor's office, right? But doing it in a way that you see your parents too, because it's hard as a parent to have a kid with a chronic illness. It's hard as a kid to have a chronic illness. There's a lot of overlap and differences. To be like, oh, mom, remember, I was going to try to do this part by myself. I want to give my description first, and then you can come in next. That kind of recognizes that they still have, perspective too. They often are still ultimately responsible for you unless you're 18. And so there's a lot of pressure on parents to feel like they're doing the right thing for their kids, right? And they're helping you make right decisions. And so I think if we can have both parents and kids kind of have that mutual kind of understanding of where each other are coming from. And then if you can keep it a little lighter to remind when your parents talking over you for the third time and they're like, mom, remember, dad, remember, we were my turn. And that will also help your provider to kind of be cued into, because some kids don't want to talk. Some kids really prefer their parents to talk about it. They don't really want to say anything. Or they think they're fine and the parents have a lot to say. I think that, you out advocating for wherever you are in that journey, over time is one of our roles as pediatric rheumatologists to help you learn to speak for yourself, to know your medications, to know your medical history, right? As you get ready to transition into adult care, And for some kids that starts at 12 or 13. I honestly have some 9 or 10-year-olds who like give themselves their own shots and like can tell me everything. They know their doses. I mean, it's amazing. And then I have other 17-year-olds who are like, I don't talk about my shot. I don't talk about what I'm trying to say. And so it just varies, but it's all within the spectrum of normal, and different personalities and just different kind of wanting to take ownership of the medication, the treatment versus not. And so I think there's no right answer for that, right? So I think that that's where you really have a really important role, both as the parent and the child, hopefully to have some of these discussions before you come to the doctor's office, but then to kind of key in your provider to kind of be like, today we're going to try me talking first and then mom. And I say moms just because more often moms come, but no offense to dads that come to visits too.
Kind of going off of that, what advice would you give to kids with JA on like how to talk to like friends and family about their condition, and like how should they approach talking to their teachers or their coaches about, oh, I'm having a flare today, or oh, I have to sit out today because my ankle's really swollen and not feeling good. How should they do that?
So again, like so many things, it's going to be individualized, right? Some kids do not want to tell anybody else they have arthritis. It's very private to them. They don't want to be seen differently. They don't want to be treated differently. They just want to do their thing. And, they modify if they need to, but they just kind of like, I'm not feeling great today. They don't give it specifics and they go about. Other people really benefit from sharing, and that is an important part of their story, and they want to share that. I think that for me, it's about thinking about, as you're telling your story, what you're telling your story for and who you're telling it to for what reason, right? So you want your friends to know, like, sometimes I can't go out when you run as fast, or I can't come play soccer right now, or I have to take this medicine. It makes me feel kind of pukey and I'm just kind of a little under the weather today, or I'm going to miss your birthday because I have to go at the 5 hours to my pediatric rheumatologist, so whatever that is, I think having a chronic illness like juvenile arthritis is part of your story. But I think what most pediatric rheumatologists, would say is that we don't want it to be your story, right? And so I think that that's the other thing about like finding the parts of your diagnosis that you need other people to know about. So you might need your PE teacher to know, because you may have to have some modifications there. I think when you're doing that, it's really important to also partner with them to say, I'm not trying to get out of PE class, right? PE teachers love physical education. They are very into exercise and health, right? So if you're just seen as somebody who's trying not to participate, it's going to aggravate them. I know a lot of PE teachers who've gotten kids who've gotten on the wrong side of the PE teacher, but they could be your best advocate, right? So those are the times when you kind of want to explain, this is what I have going on. So I can't really run, but I could do modified push-ups, or I could do some sit-ups and work on my core, or I could help with this or that. And so that you're not only participating to help them, but also in terms of recognizing the importance of exercise and strength. And you maybe do your PT exercises during a PE class, right? Like there's different ways that you can engage, but that really shows your teacher, your PE teacher, whether it's your teacher in a classroom that you need to modify something for, that you're just looking for modifications. You're all in, you appreciate whatever it is they're trying to teach you, whatever the subject area is, importance of writing, whatever it is, but that you may need a modification. And I think if you can approach it that way when you're talking with your teachers, as I'm not looking to get out of this, and sometimes you do need to get out of some things, right? But like my goal is I want to be as functional as I can be. I want to be a regular functional person in society someday. Right now I have a little blip because I have this flare going on, and I'm going to need some modifications for this period of time. But I think that doing that balancing act can be really, really helpful. I'm going to pause for 1 second, guys, because my dog is losing his mind right now.
That's okay. Kate and Bailey, how do you guys talk to your friends, or when you were younger, how did you talk to your friends and maybe your teachers about, having arthritis and like when you needed accommodations? What did y'all do?
Yeah, I mean, I still to this day, it's not quite that bad, but I'm still always like, oh yeah, my body just hates me. It's fine. Which again, I probably shouldn't be saying, because my body loves me and it's doing everything I can to take care of myself. But sometimes it just feels like
sometimes
it
fights you. Sometimes things don't work the way we want them to work.
I think for me, I'm just like you. I've never really been one to not tell someone. So if it ever gets brought up, or even in a sense of like, why are you doing this? Or how are you doing this? Like I'm pretty straight up with having arthritis, and I always have been. I feel like pretty much everyone I know knows that I have arthritis, and it was like that since the time I was 8. But I mean, when it came to like school and things like that, it's always hard, even if they do know, because people just don't understand. Like they, one, don't even know what arthritis is, or they think that it's an old person's disease. And how do you dare have an old person's disease?
I said that all the time. I said I have old person's disease. I'd be like, I am a grandma. And then over quarantine, I got into cross stitching and tea. And I was like, I'm really living my grandma fantasy right now. That was how I would describe it to people.
I mean, I still do that. I'm a grandma. I go to bed at 9 p.m. and I love to read my books while I'm in bed warm and cozy.
Absolutely.
So
Yes.
I mean, grandmas are onto something. Let's be honest here. All
They
that years of
really
experience.
I want to retire and I don't even work yet.
Right? Exactly. No, y'all get it. Yeah, no, I remember when I was like a kid, since my arthritis presented mostly in my eyes, I had lots of vision issues. So I would have to like sit at the front of class. And from like high school to college, I would just get to class super duper early so that nobody would see that the teacher had saved me a seat at the front of class, because I didn't want people to know that I like needed to be at the front, because I don't want to kick somebody out of my seat and be like, I have to sit at the front because I can't see. So I just get there really early. And like I would tell people, one of my best friends growing up knew I had like a bleeding disorder, which was like just I bruise really easily. And we played tennis together. And once a ball like flew at me and he yelled, "She's a bleeder!" So we all took it in pretty good humor, and I felt supported a good part of the time. But I did have a kid tell me I was an old person. And then I was like, oh yeah, I am. And that was in like 4th grade. I was like, yeah, I am an old person. That makes sense. Yeah.
duh. I always say that like I was an 80-year-old in an 8-year-old's body, so it's fine.
Yeah.
Absolutely. Because also as kids with JA, we have to grow up very fast because we learned that self-advocacy. So I was comfortable talking to adults more than I was kids my own age for a long time because I knew how to do it. I had to do it. But kind of talking about, talking to people, talking to adults, self-advocacy. Obviously, I'm getting ready to go off to college. I'm 18. I want to stay with you, Dr. Von Butter, as long as I can. But obviously, we're getting to that transition point. I don't like it, but it's going to have to happen. Can you speak to kind of how we're preparing for that, how we should prepare for that, like college, my own medication? When I was looking at school, student health was a really big thing for me. Just kind of that transition, that journey.
Yeah. Yeah, I think, as you said, you've advocated for yourself for a long time and given your history. Some people need a little bit more prodding to kind of learn, like, you need to learn your medicines. Next time we're going to quiz you. You need to know the names. Then we're going to learn the doses. Then but
my chart pulls through every time.
I know, right? See, learning your resources, key right there, success. And then some of the decisions have to do with how your arthritis. So some people have really mild arthritis. Some people have really severe disabling arthritis. We have better treatments today, but some people are not as responsive. So still rarely we'll have people who have really disfiguring arthritis, where they may need a lot of modifications at school or need to be closer to their rheumatologist. Usually, thankfully, from all the medications we have, most people can be fairly well controlled. And I see very few cases where it ever needs to limit where you want to go. What we recommend is really learning your history and keeping your MyChart records close to you, or having a printout so that if you had to go to a hospital, you have that record, knowing your medications, allergies, those kind of things, knowing how to tell your story. And that hopefully is happening over the years as you're getting asked more and more in clinic, which is another reason we tell parents this is important practice for kids to start learning how to describe their symptoms and remember the timeline of events that have happened, so that you can be that person when you go to a visit and you're at an adult clinic. And then in college in particular, we really advocate that people go to the office of access now is usually a common word. It used to be the disability office, so that you can register before you even get there. So that even if your arthritis has been under great control for years, maybe you're on maintenance medicines, maybe you're tapered off now, that they know that you could have a flare. And if it did, these are the kind of accommodations I might need for that brief time until I can get my disease back under good control. And might need, if you're in a big school, you might need transportation. If you have arthritis that affects your hands, you might need help with typing things or someone writing notes for your extended time on a test. And in general, professors are going to be much more tolerant of that if if that is documented before. So if they don't know anything's going on, and then one day suddenly during midterms you flare, right? Immediately they're gonna be like, oh, sure, convenient, exactly. And now what do you want? You need extra time. So you want to have all of that kind of laid out, and that if you have it, then the professor doesn't have to know you have any condition until you need them to know, right? But the school has all of that, and you have a kind of a plan laid out. So you're not in the middle of a crisis trying to figure out what you're going to do. I recommend if people go far away to college that they have an adult or pediatric rheumatologist that they see at least once close to the time they go to college, so that you can be an established patient at that institution, so that if you have a flare, then you can get in with that provider. And a lot of times that can be a private practice adult rheumatologist, so you have a lot more access to them. And then we often will continue to follow young people through college. So we'll see you on your breaks and for summer, things like that. And you kind of do that co-management again with the local provider if needed. So I think that's a great resource. And then student health, getting to know your student health. So some people can do their own injections, some people cannot. And if you cannot, and often the student health nurse can, gets a little messy with methotrexate, quite honestly, because it's officially a chemotherapy agent, even though we are not using it as such. So some student health services will do that injection and others will not. Where are you going to store it? You're going to store it in your room, in your fridge. We're going to tell your roommate about it. Or so some schools you'll have to store it in your fridge. Others will store it at the student health services.
That was a thing. My medication has to be refrigerated, and I don't want to have auto injectors in my mini fridge. I don't want it to freeze, so that was a big thing for me.
So I think those are just some of the kinds of things that you want to be thinking about as you go away. And then the common thing that your rheumatologist will often get asked is to kind of write what kind of accommodations you need. And I had a really interesting experience with a young man who was going away to college, and he wrote me a message, and it was like, Dr. Van Mater, could you write me a letter? I'd like a single, I like this location, I'd like all these different accommodations. And I was like, okay, you had foot arthritis, so you probably don't need extended time for exams or writing, right? And your arthritis is under good control. So central location is often ideal, just in case you have a flare. I usually write for that. But a single room, I don't see why we need a single room for arthritis, right? So I think one of the things, we had a really good conversation. He actually wrote me a letter afterwards, which is one of the sweetest letters. I still have it, thanking me for kind of pushing him to you want to ask for accommodations you need, and that help you be successful. But you do not want to be seen as taking advantage of a diagnosis, asking for things that you don't need, or there isn't a rationale for why you would need it, right? Because people will then not trust when you need something that you legitimately need, right? They're going to start to question, like, well, do you need that? So I think it's really important to be honest about what is the accommodation I'm asking for? Why am I asking for that accommodation? And recognize, like, yeah, everybody goes to college would like to have their own room so they can sleep when they want to sleep, right? Yep. That's a common thing. But like, what is it about your condition that would really require that over what other people should be expecting? And I think that's a really healthy way to think about it. As you're approaching adulthood, you're going to be in college, and then you're going to go in the workforce, right? And you may need some accommodations, but your employer is going to want to have a good rationale for why you want or need those accommodations. So I think it's just a good way to kind of get in that mindset early on. It doesn't mean that it's not hard having a chronic disease and having to navigate these extra things. It is true. It is harder. It is unfair. It is an added thing that you have to worry about as you're transitioning. But some of those things are kind of struggles and strategies you're going to figure out so that you can really be successful and carry those things forward. And some are going to be modifications you're going to need to keep, and others are going to be things that you can be like, nope, I'm in a pretty good place. I think I can kind of move forward, like with the general population doing X, Y, or Z, and the annoyance of having a roommate or whatever it is. So
listen, if I had gone to a different school, my second choice, they had one freshman dorm that was air conditioned and the rest weren't. And I am affected by, I can just get really stiff with atmospheric conditions. We would have had that conversation, Dr. Von Mater. Can I please get in this specific freshman dorm?
When we would have had a conversation, I was like, Kate, that's so interesting, because usually it's people when they get cold that get more stiff. So tell me about why being warm would make you more stiff. And that would be the kind of back and forth we would have, because there may be a specific situation for you, but I'm going to want to be able to justify that in a letter about why it is that you're going to need that accommodation. So that's where your provider may push back a little bit. It doesn't mean that they're not willing to write for something, but they're going to need you to explain, why you need your therapy pet for your arthritis, right? Because that's another one we sometimes get calls for. And so
emotional.
Yeah. And so then we'd say, I think talking to your therapist about, they would write that letter. It's not really for your arthritis, right? Like, even though it is stressful to have a chronic disease, that again is where we want to make sure we're being really thoughtful to make sure, again, you have the accommodations and the support you need to be successful and to feel good, but that we're not asking for accommodations that aren't within what would be expected to be needed for the medical condition.
And Kate, I can kind of say with my experience when I was getting accommodations in college, I had to go to, I believe it was like my school's counseling, because they handled all the accommodation requests. And I went to them and I was like, well, I have arthritis and I have vision issues. And so like, these are the accommodations I had when I was in high school. And this is kind of like extended time on test just because I have low vision and like sitting closer to the front of the classroom. And they said, okay, we're gonna see what you need, and then we're gonna give you a little bit more than you need just in case you do have a flare. Because I was like, well, I haven't had a flare in a really long time. Spoiler alert, I had one. And they were like, we're gonna give you more accommodations than you need just in case you do have a flare. And I'm really glad that they did because it happened.
But Dr. Von Matter, what you've said about central location, hadn't even thought about that. That is going to be really important because if I flare, it'll be in my knees. And I would prefer
first floor dorm. That's a room. I always write for that first floor, or a dorm with an elevator, although it still gets hard with fire alarm stuff. So I usually still recommend first or second floor, central location. That I'll do for anybody who has had lower extremity arthritis. Extended, like permission to type, nice. Or like writing kind of stuff out for anybody who's had hand or wrist arthritis. There's certain accommodations depending on the type of arthritis that I think most of us would always provide in case you were to have a flare. And those don't go into effect. You don't get extended time if you don't have a flare, or if your arthritis is well controlled. But for somebody who has like chronic issues from maybe past arthritis, who always has a hard time writing or typing, then that accommodation goes into place. For other people, when it's just when you're having a flare, then that accommodation goes into place when you need it, and it kind of goes back to being normal again when you don't need it. And you get to be the decider of that to a large degree.
But if you do have a flare, you will get through it and it'll all be okay.
It will all be okay. Yes.
Yeah.
I mean, some people flare arthritis. It is a thing, right? And then, and Kate's probably heard me say this, is hopefully we know what works for you, right? So sometimes it's because you missed a dose because you had midterms and it was crazy, or finals. Sometimes it's because you got the bug that the whole dorm got and you got off your medicine, or you got a little bit of a, immune, infection related, kind of a little bit of a flare. Sometimes because you're really sleep deprived, and sometimes that can trigger things, right? So you kind of figure out what your triggers are. But we also
there is nodding
know
vigorously.
Yeah. You often will know also how to treat it and that you can get through it. And so I think having those things set up ahead of time so it doesn't derail you, giving yourself permission to, like, you know what, maybe you're a fantastic straight A student, but you had a little bump here and maybe you get an A- or a B, like that's okay. Don't let it derail you and keep you from being able to catch back up and kind of keep moving forward. Sometimes the pursuit of perfection actually keeps us getting further and further behind, because as most of you guys know, it's not like suddenly one day you're going to be like suddenly ready to be back all caught up, right? It's a process. And so giving yourself some grace to not have some artificial expectation of like that you have to be the straight A or the straight whatever perfect. If you've had a bump in the road and a flare, you get over it, you move on, and that will not derail your career or life, whatever you want to do.
I will say from personal experience, I had a flare my freshman year of college. I was like I think I graduated high school with like a 3.8, 3.9. I was, most outstanding student my senior year, all these things. And I got like a D my first semester in college. So I think between the flare and college and living by yourself and all of the things, it's so much to take on all at one time. So if I would say anything, don't take all of your hard classes and try to work and take care of yourself the first semester of college, because I did, and it doesn't work that well. But going back to like trying to be a perfectionist, I don't know if it's something just because we have this disease and we have to control everything because we can't control our disease, but
that's why I am on anxiety medication.
Yeah.
Because I can't control that, so I might as well control everything else.
Yeah. And I think that that's something for your generation, because you're all young people. But this kind of idea of perfection, right? Like you have to have all A's and you have to be involved in all these clubs and you have to to get a good education, to get a good job. And I think that's a false story that we're telling people. There are tons of great colleges, there are tons of great careers. You don't need to have a 4.0 to be successful, either to get into a good college or to get to a good job, right? And so to kind of let that go, you are going to be similar to other people with that challenge of transitioning to college, right? It's hard. The classwork is different. Managing your time is totally different, right? You're trying to juggle working potentially, all the fun stuff of college, which I would recommend you be very careful about. Just for you, Kate. But it's a lot to juggle, right? And then you have this extra piece with having arthritis. And as Claire nodded, as Kate noted with the fatigue, like getting overwhelmed, getting really tired, not eating well, not exercising well, not keeping up with your medications, those things wear down your immune system. We know that. And so really trying to make sure you're taking care of yourself, have realistic expectations, especially as you transition, I think is super important.
I don't know if it's just because I have an autoimmune disease, but if I push too hard, my body shuts down and forcibly takes me out for about 2 days. It starts with sneezing. It goes to headaches. It goes to you're out, you're wiped. Yeah. And I have had to learn, in high school that's already happened. I really need to take care of myself in college.
And that's really common in teenagers in general. I think sometimes it's underappreciated how much mental fatigue makes physical symptoms, right? Like headaches, belly pain, body aches. Sometimes that can contribute to joint pain. You may come in and be like, oh my gosh, my arthritis must be flaring. I'm so sore. I'm so tired. And we're like, your arthritis looks like it's doing pretty good, but tell me what's going on. Oh, you're only sleeping 4.5 hours a night. And oh, you've been juggling 16 different things, right? Like, okay, this is, as Kate has heard me say before, this is normal people fatigue and not feeling good, right? And sometimes that's hard to differentiate, but you are just as susceptible to all the regular things that wear people and young people out and that transition. And then you have the added thing of the arthritis. So make sure you're doing all the things to kind of not flare the regular people kind of reasons for not feeling good and wearing yourself out.
This has been awesome. And I cannot thank you enough. I know Kate and Claire, we can't thank you enough for having this conversation with us today. What would be 3 top things that you would say to whoever's listening to this podcast, a JA child, any age, newly diagnosed, whoever it may be? What would you think would be the most important takeaway from our conversation today?
Well, I think you have 3 fantastic young people here. So I think what I like to tell people when they first are diagnosed with juvenile arthritis is our goal for treating arthritis nowadays is that you feel great. You do all the things that you want to do. You're not limited. You just may have to do it with a medication. And our job as pediatric rheumatologists to figure out which ones and how much. So to really not see yourself as limited. It's a little thing on your list of things that, kind of make you. But I hope it doesn't define you. I hope you don't look to have it define you, that it's a part of you, but not all of you. 2, take your medicines. They only work if you take them. They don't work if you don't. But be honest with your provider. If you're having a lot of side effects with them, just be honest. If you're missing half the doses, we might be increasing meds when actually it's just that you're not taking it. Are you not taking it because you forget? Or you're not taking it because you feel bad with it? My goal, as Kate's heard me say, is I want you to feel better. Right. So if the medicine's making you feel worse, then we got to change that up. So be honest if you're having side effects, you can't tolerate the injection. We've had that conversation, right, Kate, in terms of injection versus infusion, right? So there's a lot of different things that go into that. But having those open conversations, I think is really important. And the last thing, as a pediatric provider, is I hope that you see your pediatric rheumatologist as one of your biggest cheerleaders, right? They're here to really help support you in this transition, that you can be honest with us and tell us what's going on, what's working, what's not working, both in your arthritis world as well as other things. And that hopefully you'll see us as one of your biggest advocates, because I think that relationship, it's one of the privileges of being a pediatric rheumatologist. But I think it allows us to have, hopefully the biggest impact too, is if we can have that good relationship.
I think that's amazing. Thank you so much for joining us. And for those listening, stay tuned for our next episode. Thanks so much, guys.
The JA Talks podcast is independently produced by the Arthritis Foundation and our volunteers.